but most especially to those who've made it here in person on this cold day. This is the School Public Health Noon meeting, in case you are not in the right place. And this particular one is hosted by the Health Policy and Systems Division. My name is Jo Olivia. I'm in the division, as are my colleagues. And we're very glad to have Charmaine joining our division recently, or not recently, a few months now. And so we're extremely pleased to have Charmaine join. I'm going to let you do some introductions yourself.
Okay,
but just to say, Charmaine has this wonderfully diverse and interdisciplinary background. She's joining us from emergency medicine, global surgery work, and a variety of other experiences that she's going to be pulling into our division and into our work. And in particular, today she's going to be focusing on some previous work that she's been doing on SenseMaker, which I'm going to let you introduce because I definitely shouldn't be introducing that. But just to say welcome and thank you for joining us. And I'm going to move away from the spotlight.
Hi everyone, and welcome. I'm very happy to see some people from emergency medicine. It was a little bit of a mission to get everything set up, so I'm kind of feeling like I want to stay on one slide right now. But let us see and let us go on. So this goes back to 2017 to about 2020 to my PhD work, which was about sense making in the emergency departments using SenseMaker, which is really confusing, but I hope that after the first few slides, it will be a little bit clearer how the two concepts speaks to each other. So I want to start with context. And firstly, our accident emergency unit, emergency department, emergency center are all current terms and current correct terms. The other terms are probably slightly dated, but it refers to a very specific part in a hospital. And in South Africa specifically, this speciality as a medical profession, as a doctor's speciality, is about 20 years old. It was registered by or acknowledged by the Health Professions Council in 2003, with the first program starting in 2005. So when we talk about an emergency department in a hospital, it's an area of the hospital that, as it is functioning right now, is less than 20 years old. And I think that that is really important when we start looking at how it operates and what happens. As a nursing speciality, and I'm basically going to focus on doctors and nurses as the core team in the emergency department, the speciality has been around for a while, with it being acknowledged in 2005 only as a standalone speciality, and a Society for Emergency Nursing forming in 2009. But then the Nursing Council went through a phase where they weren't registering any postgraduate qualifications, and it's only been in the last 5 years that this has been running again. So firstly, this is a fairly new part when we speak about a hospital and how it functions. And then secondly, just kind of looking at what Google says happen in the emergency department. The first thing is that we stabilize life-threatening emergencies, sudden illness, acute care, initial treatment, and that it's unscheduled. All of these speaks to the fact that it's something that is requires time-sensitive interventions. It's unscheduled, so you can't plot that there's going to, say, be 20 patients, etc., and that the patient arriving has an expectation of things happening fairly fast. Then there's also unhindered access, so the front door must always be open, whereas when we talk about community health centers, or we talk about, say, doctors' rooms slightly outside of emergency departments or out of hospital, or we talk about OPD clinics, we talk about 8 to 5 and X amount of patients per hour. Then the type of patients that present, we have a huge variety. So we have medical patients, which would be, say, your heart attacks and strokes, requiring acute care and stabilization. But then we also have trauma care, which we know in South Africa is fairly huge problem and burden, all ages, so no separation between the really old and the really young and everything in between, and then a full spectrum of conditions. So essentially, this is a part of hospital about 20 years old, where a lot of things are allowed to happen, basically everything on the spectrum of conditions, and where there is always a time sensitivity towards And then this is the entry point for the community into the hospital system. So that's what Google says. What we see in literature is a description of how emergency departments should run. And just also to say that the first emergency departments in the Western Cape, or then in Cape Town, and probably in the country, that was purpose-built according to the new speciality of emergency medicine, was Khayelitsha Hospital and Mitchells Plain Hospitals, which is basically 2011 and 2012. So again, we're talking about an area that is about 15 years old as a custom-built area in a hospital. So physical structures of emergency departments, which is really important in sense making because the environment primes what people will see. Physical structure must be easily reconfigurable to cope with surge. What that means is in the wards, we'll have, say, 5 beds, and the 5 beds will have its own oxygen points or its own equipment, whereas in the emergency department, everything is on wheels so that we can move the 5 beds so that we can make space for 10 more. So everything is on wheels, everything's usually very open plan. So what happens is if you leave your patient in one spot for too long, your patient's probably not going to be there when you come back. The type of work, well described in literature, interrupt-driven with an increased cognitive load, which has to do with the time sensitivity on decisions, but also on the variety of things to make decisions around, and a decision-making density. This is described as problematic, that increased cognitive load can lead to errors and mistakes, but also that increased cognitive load specifically with physicians has been linked with them asking for additional tests and interventions, which then drives the cost of care, but then also actually kind of becomes a vicious cycle of that increasing the cognitive load further. So just to give you numbers, in high-income countries in the United States, a study on the interruptions, a few studies on the interruptions actually has said that they estimate the interruptions between 10 to 16 per hour and at least once per task, which means that, and this is specifically on emergency physicians, not on nursing staff, but it essentially means that no one in the emergency department gets to complete a task without at least one interruption. Information flow is convoluted, usually asynchronous, and again, this is well described and on few levels. So the first thing is that the administrative part of the hospital typically doesn't speak to the rest of the hospital, but then nursing and medicine typically also don't speak to each other. And in the emergency department, where people are super dependent on each other, that is a huge problem, that doctors can't access nursing notes or nurses can't access doctors' notes. And then we have service providers like radiology and pathology who typically also don't give the information through into one coherent whole. It's busier when the hospital is quieter, twofold. So firstly, South Africa with massive trauma burden, a lot of patients present after hours and over weekends, when the rest of the health system, or a lot of the health system that works on 8 to 5 is closed. So when radiology is really needed, they might be closed. When pathology is really needed, it might be closed. When a patient needs to be moved to the ward might say, we're waiting until the consultants return on Monday. But then secondly, there's also a problem where when some of these services drop off, the onus is on the emergency department to step in, such as if there's an emergency in one of the wards, emergency department staff needs to go. If pharmacy is closed, the keys are typically left in the emergency department. So it's kind of double thing there. And then this is the last one on that, and then we start getting into sense making. But I think you're starting to understand why this was such a big research question. Occupancy, the acceptable global occupancy rate sits at 85%. What that essentially means is that we always, or in a hospital, you always want to have 1 or 2 beds open so that you have options if patients come in or if patients deteriorate, there's space for them. And a study in 2017 done in public health, actually at UWC, found the average occupancy in Cape Town emergency departments to be 270 to 340%. What that essentially means is there's never enough beds. So as people are looking at their patients, they need to kind of make a judgment call of whether this patient in acute pain really deserves that bed or not. And patients are often seen in chairs and often for a few days, and they sometimes also in waiting area, or they might be discharged prematurely, which then puts a burden on kind of the rest of the system. I think one other thing to say here is that the emergency department becomes a safety net as well for primary health care, which also often runs on office hours. And if they are closed and a patient couldn't make it or was in a waiting list, they might present at emergency department after hours. So when I was thinking about research questions and taking study further, the question that I had is that this environment, everything is changing the whole time. There's this huge variety of things happening. Decisions need to be made immediately, and no one holds a complete picture. It is absolutely impossible. So everyone has little fragments of information within different teams, and I'm only talking about the doctors and nurses. I'm not bringing in the rest of the team. That could be admin, that's porters, that's security, etc. How do people actually figure out what's happening? And specifically from an operational perspective, because clinically this would be a nearly impossible study to do. So how do people know that we're sitting at 370% occupancy and we need to make really big decisions on which patients should go or stay? How do people know that resources are low? How do people know we need more staff? How do they just actually figure it out? And who do they then interact and share their emerging insights with, because things are constantly changing in a dynamic field? And then what happens? So that was kind of the quest of sense making. And then if anyone kind of knows some of the big scholars in sense making, this is one of David Snowden's kind of sayings to try and define what sense making is how do people, how to make sense of the world or the environment in order to act in it. Because sense making is really closely linked between cognition and action. And it seems to be a perpetual kind of question of whether we act ourselves into cognition or knowing, or whether we know and then act. And that's kind of the sense making quest. So this very, very briefly is the four kind of main scholars of schools that I looked at for sense making. The first, Durban, in some circles, well, the best known, looked at individual sense making and disregarded the kind of social environment in which a person would make sense, yet was embedded in communication theories. Gary Klein looked at, specifically started out looking at firefighters, naturalistic decision making, which at that point was in the early 80s, was seen as very new, because he basically said people don't make logical, rational decisions. They only make decisions or sense up to a point that something appears plausible. So we need to kind of change things in the environment to make things look plausible. Vac described it in organizations or sense making, and specifically said that it's collective and it's socially regulated. And then Snowden, anti-complexity. And this basically speaks to, we have complex systems within complex systems, because as soon as we bring the human into it, we have a different layer of complexity. So in a lot of kind of naturalizing sense making schools, we look at nature, biology, etc. And Snowden made the argument that that's one complex system. But then we bring people in with different identities, intentionality, and intelligence, and that's a whole new field of kind of complexity within complexity. So just the little words at the bottom is kind of some of the big themes. That emergence is we never know and understand. A lot of use of verbs within sense-making theories, plausibility, and then the feedback processes, which is socially regulated. And this is often disregarded in organizational studies, where we only look at kind of the lines between processes as opposed to people and their identities. So the SenseMaker tool, that was just to remind myself to actually talk about the water cooler conversations, which I'll get to on the next slide. So this study, we looked at 5 district, regional, state emergency centers, usually with the SenseMaker study, and I'll talk a little bit more about that now. Oops, that was premature. The data is typically shared with the participants, and they tell us what they make of the meaning. So that's called narrative action research. We didn't do that in this study, so what I'm sharing with you is pretty much my interpretation with my supervisors, as opposed to be narrative action research. But what we also did was we reviewed the utility of the SenseMaker tool as an academic tool. So SenseMaker is that water cooler conversation. So what happens typically, and I'm going to talk about organizations because that's where my study is, this happens in communities as well, is we're talking now, and after this kind of conversation, you guys walk out and you kind of immediately say to each other, I have no idea what she just said. But while you were here, you were clapping hands or saying, you know exactly what's happening. So the whole idea of SenseMaker was to try and capture those kind of informal conversations that is happening, because that is really what drives change. That is really what drives organizations, if we talk about informal organization, or if we talk about the shadow organization. So SenseMaker tries to capture those attitudes and beliefs that sometimes sits just under the surface of a group. So it's situated as a complexity appropriate method, so that whole concept of human systems within complex systems. And what we do with SenseMaker specifically is we try to find patterns in what people are saying. So the more stories you have, the more patterns you have, and the more you can use that. So we capture little fragments of stories, not long stories, and then the storyteller will self-interpret their stories in a signifier framework. And we're going to go through that, so I appreciate that it might sound quite confusing at the moment. And then a lot of people think that SenseMaker is qualitative research. It isn't actually. You have stories, but you have a framework that gives you quantitative data, and that is used to explore the patterns. So apologies if this was confusing, but at the next slide, we'll kind of get back to it. So the more stories will give us stronger patterns. We aimed for 100, we had to set them for 84. We shared it with people as a link. At that point was quite tricky, partially because we were going on HR departments, email addresses of staff working there, and that is actually not accurate. So towards the end of my data collection, I had to go to facilities and ask people to participate. So what we also do is we use different kind of findings to slice other findings, which I'll show shortly as well. And then you can access the stories to strengthen or explore your patterns. So you're not actually accessing the stories so that you as a researcher decide what it means. You're looking at the patterns, and then you access the stories to see what is happening in a grouping of patterns. Usually no external analysis, which I've touched on. And then for analysis for this study, I used RStudio, but there is a SenseMaker workbench, which actually gets far prettier data than my data, which might just actually speak to the fact that I can't use RStudio properly. So story prompt, we're going to get into the data soon, I promise. The story prompt was we asked people to tell us a story about a time that they were shown a new colleague around in the emergency department, and they were interrupted for something challenging, and what that was and how they would advise the new colleague to deal with it. And then they had to give a title and a metaphor. So something that was really interesting is hardly anyone answered the prompt. People kind of just saw this as an opportunity to share frustrations or something that was fairly recent in the month, something that happened that morning, etc. And other people had little bullet points of things that it could have been. So then what happens, and now we're starting to get to the cool stuff, is we designed the signifier framework to kind of have neutral answers. So if you look at the triangle, that's called the triad. None of those answers are right. None of those answers are wrong. So we want to have kind of three neutral points, and then people use that little ball to pull it to what they sense or what they think is the answer to their story. So in their story, in a challenging situation, they were most hampered by information support, power to influence. None of those are wrong. None of them are particularly right. One person answering this is not meaningful, but if we have 100 people answering it and all of the answers are kind of grouped together somewhere, that tells us that that's a pattern, and then we can look at the stories. On the other side, we have the dyads, and on the dyads, you'll see it's extremes. So again, we kind of put in an extreme so that people can't, like on a Likert scale where you put a 3 in the middle and everyone gives neutral answers. This kind of forces people, even if they just slightly move that ball, it forces them to choose aside. So here, availability of required information was just simply too much or too little, and they are left to answer that. So the first kind of like patterns, this was diet. The availability of the required information was too late, too little, too hard to find, or too much, too early, we were swamped. What we found people answer here is fairly kind of even distribution, leaning a bit more towards swamped, which we could think with everything we described about the emergency department makes a lot of sense. And we're going to break that down shortly, just show you a second one. In your story, so in a challenging situation, in this area that is so full of time sensitivity and so full of pressure, the best way to communicate in this challenge is using formal channels or informal conversation. And again, here we kind of find a split where there was kind of formal versus just chatting about it. And again, we can look at that and say, okay, fine, but this depends on the situation. True. But now we go and we start slicing it, and we use demographics and we sliced it. And what we saw was the doctors predominantly said that you chat about it, whereas the nurses predominantly said we need formal communication. And what we could see in the stories was that the doctors would say, well, the nurses and I were chatting about X, Y, Z, and I walked away and I came back and the nurses didn't do it. And I don't understand why the nurses are so obstructive. And then the nurses on the other side were saying, you know, these doctors just don't make decisions that we can act on, because for them, the decision had to be written down. And neither one's right or wrong, but what we can see here is that there's a disconnect between the communication channels, which means that in this environment, we probably have some issues with communication. Now we can kind of look at it from a kind of Goldilocks perspective, where we can say too much information is not great, too little information is not great, but what is the information and the communication that needs to be in the middle? And similarly, if we look at information, the doctor's kind of in the middle, the nurses completely swamped, and there was some that were at the point of lacking. I didn't slice it more because I appreciate that this is already maybe a little bit confusing, but what we found was the lower category nurses were completely swamped, higher category professional nurses were lacking. Similarly with the doctors, the more junior the doctor was, the more likely they were to feel swamped with information, and the more senior doctors were kind of in the middle. So I'm going to carry on to the next point, but I'm probably going to come back to this. So in situations like your story, when information and explanation do not match, it's best to. And this is kind of speaks to the work of Gary Klein, which is on kind of sense making, I suppose, but on how do we pick up abnormalities or anomalies in this kind of flux of information. So you'll find that your information and your explanation isn't matching. So example would be, say, a patient sitting in the waiting room that is kind of, as you walk past, it's like that patient's a little bit too bad to sit up on a chair type thing, which I know is a clinical example, but that is a patient that needs bed, which makes an operational decision. So the kind of options was live with the difference, check and reinterpret information, or look for additional information. And if we look at this, it kind of looks quite cool. It looks fun. People were choosing different stuff. But then we went and we sliced it with how people viewed information. And what we found was that people that's feeling swamped with the amount of information coming in were more likely to live with the difference and say, well, it doesn't fit. This doesn't fit. This isn't making sense. But I am a bit swamped with information, so I'm just going to ignore it. And when we start looking and talking about high reliability organizations, we want people to have a kind of preoccupation with failure. We want people to look at abnormalities and say, this isn't working right, let me go back and recheck information. So this kind of points to an issue with sense making. So we kind of accessed the stories there, and I just summarized it. So firstly, it was mixed roles. So it was about equal distribution between doctors and nurses. Emotional tone was a question that people were asked, that after your story and once sharing your story, how do you feel about your story? These guys were very likely to feel very negative about the story and the episode. And the stories were stories about, I felt alone with a patient, I couldn't control the situation, no one was helping me, which kind of grouping that together that way kind of speaks to a few things that could be fixed or could be addressed within the organization's culture, and that this was kind of between the doctors and the nurses. I just want to say something because I appreciate some people online might be more kind of epidemiologists or in really quantitative research. We don't typically use p-values here because we're looking for patterns and not for what is statistically significant. But some of the later updates of SenseMaker now allows us to also have p-values that we can say that. Okay. So just 2 more slides on this kind of section of work. So here we took 2 of the dyads. So we put the consequence of decision. So there was a question where it was the decision that had to be made here was really obvious or it was really confusing. And then the one on communication was formal and chatty. And this gives us a slightly different kind of pattern distribution. And what we have here is those little clusters of stories together. What is really interesting, and for me that is the beauty of this tool, is that when we start looking at the stories, we can see a distinct difference. So the people that were saying that they want formal communication and that the decision that needed to be made wasn't that clear or was confusing, or actually spoke about things that the emergency department could resolve or the leadership could resolve. They were alone with the patient, there was no one there to help them, their inputs weren't considered, they had no orientation, they were just expected to work and didn't know where stuff was, etc. Dealing with multiple patients with no help. So this is all stuff that within the daily running of the facility or of the unit could be addressed. Whereas the people that said that things were obvious, but also wanted formal communication, offered great solutions, none of which is very practical. The first is use set staff ratios, which is typically set on the number of beds. So we have, say, a 20-bed emergency department. We're going to give staffing for 20 beds, but there's 90 patients. Doesn't actually address the problem. Patients must bypass the emergency department, go straight to the ward. It's not going to happen. Inpatient teams should do more. Could happen, but nothing that people in the emergency department can resolve. Or management should take responsibility. And again, this is something that is happening outside of the emergency department. So what we could do is to take this data back to groups in the emergency departments, ask them what this means, which stories they are kind of happy with, which stories they aren't happy with, and how we can then change the stories to basically improve things on the ground. Enactment. So enactment really speak about this action that gives you understanding of what's happening. And this question was just one that I wanted to show about that theme on support. In your story, you were most hampered by support, informational power to influence. And we can see that there was really kind of a strong move towards the fact that people just didn't feel supported. So that was all the SenseMaker tool. Now the bits that's usually not done, which is the narrative analysis. I did inductive thematic analysis, including the stories, the titles, and the metaphors. So let's start in the middle there. There were kind of 3 themes. I know that was the usual thematic analysis. It would be 4 next to each other. Just give me a minute. There were basically 3 main themes. The first one was the usual chaos, where people told stories about what it's like to work here. They shared clinical examples, and then they spoke about mental health patients, which is also a huge burden. I'm not quite sure if it's a Western Cape thing, if it's a South African thing, or if it's a global phenomenon, but there's not enough beds within the province for mentally ill patients. So what happens is when they present to emergency department, they're kept in the emergency department often up to 21 days, and they are kept in one room. They have requirements that can't be met in the emergency department. And I think one of the most obvious ways to think about it is if you're slightly paranoid or psychotic and you're lying in a bed where there's patients moving past you the whole time, the lights are never turned off, and there's constant noise, that's really not conducive to the care of that patient, other than the additional kind of pressure that it puts on the staff here. So that was the usual chaos. Set up to fail was kind of known issues that's well described in literature globally, such as crowding, that's when there's more beds in, the borders, which is patients that are in the emergency department waiting to go to a ward, waiting for the wards to have available beds. And again, sometimes they can also stay quite long. And then just the pressure that all of this kind of puts on staff. There's no help came, and I think that the last kind of triad spoke to that, is that the people working in these emergency departments felt that the rest of the hospital can close the doors and say, well, we had 85 occupants, we can't take more patients. But then the rest of the healthcare system can also say, it's 4 o'clock, we're closing our doors, and everyone just leaves their patients in the emergency department to resolve. So it was stories like that. And then there was a little bit of a theme through of, I'm doing so much, that's not my job. And again, that kind of concept is not great from an organizational culture perspective when people are feeling that 70 or 80% of what they're doing isn't their job. And all of that results in this theme that keeps coming through on the metaphors and the titles, to the extent that I actually asked a clinical psychologist to go through it and give me inputs, and I thought I may be reading the same stories over and over. But no, most of the stories had some reference to this being a war zone. Stories about hostility, stories about verbal and physical threats, stories about being abused, and then just this general kind of use of warlike terminology that I think that it really kind of connects back to what we saw in the SenseMaker results, where, and I'm going to use the words of Anne Lamott, who's actually just a writer, not a scientist, but why this matters is because metaphors are a great language tool. They explain the unknown in the terms of the known. So if we look at life as a roller coaster, say, then when we kind of on a down, we're kind of looking forward to the up, because we know that after down there must be an up, because that's how roller coasters work. If we are looking at life as a game, then we can think that maybe I'm on a losing streak, but my luck's going to turn soon, because that's how a game works. And when we think about the workplace as a war zone, what that means is we're going to work and we're ready for the battle today. And that means I'm going to protect my information. I'm not going to collaborate with people across boundaries, and I'm going to be territorial. And that then becomes the kind of values that people are basically, or the taken for granted ways of how people are then acting in the workplace. So this, for me, is a very important narrative to try and shift. And the narrative can be shifted by kind of looking at which stories were specifically about war zones, which was most of them, and then which stories were maybe something else that we want. And what we need to know is that the opposite of war is not peace. The opposite of war in a workplace would be collaboration, co-creation, creativity, and a lot of things that we want, like innovation. So kind of in conclusion, the whole study, there was little evidence of collective sense making, which is probably contributing to how people are experiencing their workplace. Because it is still such a new kind of speciality and part of the hospital, there is an opportunity to kind of tackle some of these issues now. Evidence suggested operational disconnect, which could also extend to management of facilities and kind of the broader healthcare system. The emergency department itself is a risky environment for operational failure, adverse events on patients, but also burnout for staff and other issues. And we can shift the stories and prime the environment to improve sense making. And then just the last point on that is SenseMaker is exploratory method. So we went in with this kind of broad question, and it generated quite a lot of research questions out of that. One of them that for me is quite an important one is looking at the information and the communication, is kind of mapping those. We haven't mapped in South Africa, we haven't mapped the number of interruptions, etc., which is really emergency department specific, but then broader, it is how can we really address how things are done in the emergency department right now. So thank you very much. That's me. I don't know if any questions from you.
Thanks, Charmaine. I'm going to let you handle the, if that's okay,
questions.
Two of us standing up front, there seems overkill. Maybe we should start in the room and see if there's any comments or questions, and then go to those online. The speakers above your head, so if you at the back of the room, you might need to project. that way.
Well, that's fantastic, Charmaine. Thank you very much indeed. Really interesting. I guess my question is a methodological question. It's like how have you conceived the linkage between the SenseMaker analyses and your narrative analysis? So how does all the very granular insights into what's going on link back to the broader?
Should we just maybe take a couple of questions, or is it, do you mind if it just?
Yeah, because I'm quite sure Ruth's questions probably also going to method. Not.
No, I'm here to learn about methods. So, no. But you said some things, I wrote it down. How to change the stories to improve things on the ground. So I have two questions on that. One is not quite understanding changing the stories.
Okay.
And then secondly is how it actually affects the ground. So what's that kind of application? Or was there any? Or what's the potential?
So, and I think that I can actually take the two questions together, unless you're.
You go ahead.
Is it similar to this?
It's kind of similar, yeah.
Ask, and then we can.
So, you mentioned briefly that some of the more senior staff seem to be making sense of their lives, the chaos and the information flows better than the more junior staff. However, most of the stories and the thematic analysis seem to be about the more negative experiences. And I wondered if there wasn't in the research a way to highlight the deviant cases, which would be sorry, for those online, I'm waving my fingers. Those are usually the people that are coping and the people that are making sense of this chaotic and complex environment. If there wasn't a way to highlight how they were making sense of the world, even if they were in the minority, but then also finding a way to onboard the others more rapidly to get to that point. I suppose all of the examples of the stories seem to be from those who were quite not coping.
And so that's an interesting point, and I think the three can go together, but let me quickly just answer yours very briefly. What was also interesting, and that was one of the reasons why I spoke to a clinical psychologist, is, for example, one person told the story of basically being physically injured and kind of assaulted, and then rated the story as really positive. And I was like, there's something wrong here. And in the end, I kind of tried to cut out a lot of the emotional tone because I wasn't sure I could interpret it. But there was about a 50-50 split. Most people actually feel quite positive about working in the emergency department, even though their stories could be seen to be slightly negative. But I think that in answering Lucy's question and answering Ruth's question, maybe that would also be clearer. So in a kind of typical SenseMaker scenario, what would happen, and it was seen as too big for my PhD, but what would happen is once I collected the stories and I did a first kind of analysis, I would take that back in workshops to the different kind of groups that participated. And then what you would do is say that same triad with the live with the difference. You would put that up with the stories and the group that's sitting there. And this is how it's also been done in a lot of kind of community settings. They would then say, oh, but we don't want those stories with living the difference. So we need to shift those stories. And then what you do is you look at, say, the other triads, or you go back and you look at the stories and you find the stories that you would want. And then you say, we want less stories like this. We want less stories of people saying that they felt isolated, that they were thrown into this chaotic area without being oriented. And we want more stories. And one story that really comes up was a person saying that everything that happens here is because of goodwill. We want more stories of people saying that there's so much goodwill here. We want more stories of people saying that we're such a close team. And then kind of looking at what's the type of actions that we can shift the stories. And then you can repeat SenseMaker again once or twice to get there. So what I did for my kind of PhD academic study wasn't quite how you can apply it in a real setting. I think that my stories, according to me, really added value. My narrative analysis added value because that theme coming through of the war zone to me was quite an important theme that I think kind of explains stuff like people feeling they're not supported and therefore they're seeing it. And now you can argue, is it because they're feeling not feeling supported that they're seeing this as a war zone? Or is it that because they think they're in a war zone, they are really skeptical of people wanting to support them? them. So I think it can go in both directions. I think there was huge value in doing a narrative analysis. But I also appreciate this is often used as an organizational real-time decision-making tool where you then don't have the capacity all the time to do a thorough kind of analysis. So is that kind of answering your question? Well, both of you, I suppose.
My side, yes-ish. I suppose, so I could understand that the narrative analysis that then reveals the chaos of the environment, that big picture story, you might unpack it saying, well, what leads to that chaos? It's people want different types of information, they don't talk to each other. So I suppose it was that sort of linkage I was wondering. You raised another question.
But I think just to quickly come back to that, and that's maybe something else I should have said, is that especially if you're using SenseMaker Workbench, so if you're using the SenseMaker kind of software suite, you can access the stories as you're doing the kind of quantitative analysis. So you draw a little rubber band or you make a little circle around little dots, and you can immediately access the stories, and then you can find the patterns. And I found it really interesting, especially on that one where I had the two diodes next to each other, that you could so clearly see a pattern between the stories that were told at one end versus the other end. So you can do that in real time, and that thing kind of gives you the ideas of how to strengthen it. Your other question on that?
So as a point of clarification, it's a method clarification, because my understanding is that, is this correct, that SenseMaker is used, the participatory analysis of the stories is about then being able, it supports people acting in the environment or changing their narrative because they're engaging with the stories, whereas obviously you used it more as a research tool, sort of steps away from that participatory analysis.
And I was going to share it kind of as a postdoc research project, but then COVID hit in 2020. I submitted February 2020, and a month later we were in lockdown. It didn't seem like an appropriate time. And now the kind of question is whether it would still be appropriate to take these stories back when there's a lot of other people working there now, and some of the things might have shifted. But yeah, definitely something that you want to take back. And then in taking that back, people can say, oh no, but these stories aren't important. Or what it also enables is, and I've used this slightly on another kind of theme, but I've used this in the classroom. I tested it in classroom, and what it enabled us was to have really actually tricky conversations in an anonymized way, where we could look at the patterns and then talk about it.
Maybe this
Yeah, I just want to hear, is there anyone online that wants to say anything? Any questions online? Peter.
Hi, Charmaine. Just well done. It was a nice presentation. I've heard you present it a few times and it gets clearer every time. Yeah, my uncomfortable question that you're probably not going to like is your PhD came out 5 years ago, and we appreciate you've done an amazing description of the problem, but I don't know that we've done anything to tackle your findings and where to from here.
Absolutely. Thank you, Peter. I think that's a really valid question. And I think it's now becoming to that cusp where I'm like, oof, I'm doing another talk on my PhD and it is slightly dated. And I suppose I can put the question back to emergency medicine on, if we found a way to take this forward, whether this data would still be seen as relevant, or is this something that should be a repeat study? And I suppose just to add on that, I also think that there's some things that have shifted. So at the time that I did the study, it was really difficult to get hold of participants. And there was a little bit of a fear of using links, etc., for research. So it's also a question of, would we maybe be able to get more stories? So I'm kind of throwing it back to you, Peter. What's your thoughts?
I've got not the slightest doubt that this is still relevant, if not more so today. I think COVID threw a spanner in that has maybe made us all more aware. But yeah, I don't think anything's changed.
And I suppose just the last thing to say on that, I published a paper last year, December, specifically about the narratives, and I had people from Ireland mail me and say that this is exactly what they're experiencing. So I think it is still relevant. Eleanor.
I was so my question, I was trying to formulate a question about sort of how South Africa or Western Cape specific your findings were, and it was related to a sort of broader question about, and I was going to ask you, before you mentioned asking a psychologist's opinion at the end, I was going to ask, is there sort of behavioral psychology theory that helps you to understand, you know, like why some people thrive in an information-rich, interruption-driven environment and why others don't, and sort of, because it's when you were describing the context at the beginning, it seemed like those were sort of necessary universal facets of an emergency department, and then you could learn something that's quite, that's not actually contextual at all, but that's about like human nature and decision making in complex environments.
I love your question. Marlene, is your question related to that?
It's slightly, but I just wanted to comment. I found it really fascinating your description of the emergency department in the context of the broader health system, and how I think the other parts of the health system don't necessarily appreciate these characteristics of the emergency system and how the other parts of the system impact on what goes on in the emergency system department. I think that in itself is something worthy of discussing in the broader health system. My question was, I think especially now, in terms of the human resource crisis that had deepened, that there's a lot of agency work going on now. So nursing agencies that start through the emergency department, locum agencies that rotate younger doctors through emergency departments, and how the stability of a core team might then differ from all of these people that come in and out and rotate through several different kinds of emergency departments. How that narrative for those two different groups of staff might differ, and whether some of the being overwhelmed, the more staff being overwhelmed, might also have to do that they're not part of a stable core team, but they're rotating through these and come every couple of weeks into an institution and out the next day, and so just thoughts on that. But I just really wanted to say I think it's a fascinating account of the place of the emergency department within a health system and the relationship with the rest of the health system.
Thank you. And I think that is also some of that kind of tension, is also some of the negative war zone perspectives that needs to be explored, because else we'll lose people. I think, Eleanor, to go back to your question, I think, so firstly, I didn't look at human behavioral models. I went deeper and deeper into kind of sense-making theories. It's really my favorite topic. I listen to things about it all of the time. And a lot of the work that has been done in sense-making, especially Klein's work and Vik's work, were really about kind of crisis situations and places where people are making time-sensitive decisions. So that is your fighter pilots, that's your firefighters often, neonatal ICU nurses, the emergency department, lots of work in emergency departments, Formula One teams, changing tires, stuff like that. So a lot of the kind of literature is around that, rather than say human behavior per se, although that is still human behavior. Durban's work was really communication in libraries, and then I think Snowden's initial work was knowledge management in a large corporation. So I think that there is, it kind of speaks to broad ways of sense making. I think that emergency centers, I think different specialities within healthcare attract different type of personalities. And I think that there's a certain type of personality that thrives in the emergency center. I think that, you know, there is more work to be done on this topic. I mean, kind of to link that to Maylene, I'm not sure if I've actually answered your full question, but to link it to what Maylene was saying, and that was one of the things that we found with that overwhelm. Not only was it the nursing kind of the categories, but the other interesting thing is, and that's why I was kind of hesitant to mention in the beginning about the emergency nursing speciality, because the emergency nursing speciality is something for professional nurses. But about 60 to 70% of the nurses employed in the state emergency departments are lower categories. So they don't even have the option of specializing. That's kind of a private healthcare thing that you can specialize and work in a net care or a mediclinic without specialization. Whereas in our state facilities, it's really the lowest possible categories. Furthermore, triage is developed within South Africa. The South African triage scale is developed so that the lowest possible category of nursing staff can do the triage process. And that's amazing. There's been a lot of studies that show they can, but I think what my findings suggest is that maybe cognitively they can't, because there's a load on them, because the person doing triage is the person scanning the waiting room, where overflow of patients are often looked after, and where patients are coming in that are not yet triaged, that are not yet kind of appointed to acuity. So there is a question around that. And then often what happens is when there's agency staff around, because kind of the triage room is like one spot where you can just put people, they will end up being the people in the triage room, so that you can have the resources at the back where people know where stuff is. But essentially what that means is that you're putting the person with the least knowledge about the system in the one spot where they basically directing the flow. And I think that is also problematic. So I think it is a very interesting question, and I think that if I were to do this study again, I'd probably have a filter in to try and catch people that are locum staff versus not, or maybe work there for less than 2 weeks or less than a month, because I think that is also important findings.
Thank you. I just wanted to acknowledge Tabo put a comment about how they're going to be using SenseMaker. It's a comment, not a question. So maybe that's something for future discussion. I don't see any other urgent hands online or in the room. I think the conversation is to be continued. Thank you, Charmaine. Sorry, were you going to?
I'm just curious about Tabo's study, just to understand what the focus of it is going to be. Like,
SenseMaker for what?
Yes.
Let's see, Tabo. Tabo, quick. You're being asked what you're going to be using SenseMaker for in the communities.
No. Karen is there. Karen will help. Is Karen there?
Yeah, can you hear you?
Yeah, Karen can respond to that.
Hey. I don't see Karen.
Okay. All right, we're doing a sentinel study on asthma. In 7 sites in Limpopo, Northwest, and somewhere in Cape Town.
Okay, great. And thank you. To be continued about that for sure.
Yes, Barbara, I would be happy to chat with you if you want more information or some insights or some help.
Yeah. Well, myself, Simon. Okay, there's someone.
Hi, Charmaine. I was going to ask a question as well. I work with Tabo and with Karen at a Lung Institute. So we do a big project on asthma. We are very much in the preparations, finished the proposal, which is now going through ethics, and we plan to collect data in next year, starting next year, longitudinal. And so having SenseMaker at multiple data collection time points throughout 2026. It's going to be it's a complex study with medical and also with geological and climatological measurements. So we are, Tabo and myself, are a part of the community engagement. So we are looking on the ground, how do people engage with asthma? So the patients themselves, which are children, maybe the parents and other people in their houses. So we want to use SenseMaker to get a grip on how do people think about asthma. So your presentation is very helpful. I love the diagrams to see. So I heard about you can have dyads and triads. So it's very enlightening for us to see your diagram. The one question I had at the moment was related to your, there was a diagram that you showed with the square, in which you had 2 dimensions, communication. Was there other one, complexity? And
So
so
that-
I was wondering, how did you make that? So how you come to the diagrams for the triads and dyads makes sense. How did you make that square diagram? And how do you need something specific in the data collection itself with a formulation of questions to make that possible?
Okay, so quick answer on that was 2 dyads that I put on an X and a Y axis using RStudio, which is the harder way to do it. If you are using the SenseMaker tool, it basically comes with a collection tool, but also with the analyst tool that allows a little workbench in which you can pretty much play around with that.
But Simon, I think, thank you for the question. I think it's quite a bigger question.
Yeah.
So maybe, Charmaine, maybe an email or
Yes,
conversation. It sounds like your team needs an email conversation with Charmaine. Unfortunately, we just don't have time for a full response. Sorry.
I'm dropping my.
Thank you very much. I just want to say thank you so much, Charmaine. And I'm going to wrap it up there. Thank you. Charmaine's given her email address in the chat in case you want to get hold of her about using SenseMaker. Charmaine, thank you. We look forward to hearing more about it in the future. Thank you to everybody who's joined online. Thank you to those who came in person. And that's the end of the noon meeting. Thank you very much.
I'm still sending my message to Tabo. Wait. You just do that. I'm just gonna.